Hi, everyone. Thank you for joining us today with our talk show panel. You know, everyone today is talking about stories. So, on today's episode of our Community Health Work Review, we have a special episode dedicated to our celebrity authors from the textbook promoting the health of the community health workers describing their roles, competencies, and practice. What a treat we have in store for our viewers today.
Oh my goodness, Susan, we are so lucky to get this panel of celebrities to share their stories. Our CHWs and allies for taking the time to sit down and talk to us today and to share these stories from their hearts. We often have to explain who CHWs what they do, but here our noted authors are going to answer the why question. If you ask me how you, they might respond, and probably should, everything, and that would be just about right. Seemingly, community health workers fill a number of roles in official and unofficial capacities on the clock and off the clock. CHW change agents in their communities, which requires multiple roles and activities. Regardless of all CHW-like positions that fall under the CHW umbrella term, they include common roles and talk today about these 10 roles, and these include, drum roll please, cultural mediation among individuals, communities, and health and service systems, providing culturally appropriate education and information, care coordination, case management, and system navigation, providing coaching and social support, advocating for individuals and communities, building individual and community capacity, providing direct services, implementing community assessments, conducting outreach, participating in evaluation and research.
Oh my goodness, we only have an hour. We better get started.
Community health workers play an important role in mediating how communities understand behavioral health and are able to assess engage in behavioral health services. Neem Kikret, who is a CHW from Reach today. Neem, you shared such an important story about cultural mediation with the. Will you please tell us what you wrote in the book?
Hi, everyone. Prior to the COVID pandemic, I was working in the clinical pediatric primary care setting, and I was called to assist a behavioral health clinician and pediatrician who was seeing a patient with special need, and the family speak Khmer. Due to the language barrier during the appointment, the behavioral health clinician and pediatrician thought that I could help interpret it during the office visit. But as I introduced myself to the family, I learned that the mother of the patient and an uncle was accompanying the patient to see the behavioral health clinician and the pediatrician. But the uncle was interacting with the patient just like he's the father. As I introduced myself and learning during the office visit, that the behavioral health clinician and the pediatrician referred the patients to the Center for Children with Special Needs, or CSN. As we talk about this referral, the mother stated that she looked up the word autism in the internet, and she learned that the word autism means crazy. Just like, have all this refusal, don't want to go for the referral. Just like my child is, okay, is doing well. And this was an opportunity to speak with the patient family about the meaning of the word autism. The different words we use for behavioral health issues, such as the developmental delay. That autism word is one word used to describe growth and development delay of a child, and can be different in some children growth. This was really an opportunity to educate the uncle and the mother more about development and developmental behavior, and that autism can be mild, can be moderate, can be severe. This was an opportunity, and the word autism does not really exist in the Khmer language. In Cambodia, if there was any services at all, would be in a mental health facility for behavioral health issues. So during this visit, we shared that the word autism symptoms such as don't want to be touched, don't want to have eye contact, does not want to speak. The patient can be shy. The child is, can, in some cases, can really excel, such as in math or music. So after hearing this, the mother stated that her child improved it at the school and that he's no longer in a one-on-one class. So as the mother listed the strength of the patient, that he have lots of friends, is talking more in class, is interacting well in class with his classmate, and that he have good feedback from the teacher. So the more we talk about the strength, the more we share this information, then kind of go back to share with the mom and the uncle. So the behavioral health clinician and pediatrician really wanted the patients to get in evaluation at the center for children with special need, and would they willing to book an appointment. When I said evaluation, it is, it kind of explains to the mom and the uncles that, looking what are his strengths, like you said that he's doing well in class, but can he, is anything that we can get more support for the child. So after talking more about it, the uncle and the mother was willing to have an appointment for the evaluation. And, they stated that they hope that the patient would grow up, continue to have friends, and able to get a job. Julie?
Yes, thank you so much. So what do you think are the most important about behavioral health prevention and promotion through community health workers' expertise and cultural mediators?
I really believe that we have to listen to each case, each patient, each family. They come in with role, expectations, ritual, custom, all these things, and how are they interacting with the society, what do they practice, what do they know about health, what are their economic status, all this SDOH that's contribute how they make decisions, how they access resources, the language that they use. This is the example of the word, autism, it could mean different things to each individual. So it's the community health workers, how do we become a great community health worker and be a great mediator, cultural mediator to the patients, to the provider, listening to the provider who are following all the the social services, the health services system that are regulation requirement, criteria, performance, all these things that are set in system. And then at the same time, the family, the patients, there are need, their expectation, they come in, they might thinking, well, the provider, the expert, if the provider tell me, I do it. But then at the same time, in behavioral health, there are shame, there are stigma, there are worry. You have the pre-diagnosis, during diagnosis, after diagnosis, and then are they able to get services at school? They are school age, and so as community health worker, I think we continue to engage the family, listens to the family. Is the family of seeking, identifying the health services, engaging in the health services, accessing the health services, and advocating for health services in the community. Julie?
Wow, that totally answers the why question in my book. So thanks so much. Well, right along these lines of cultural mediation, we also have centered health education and information as one of the oldest and most fundamental roles of community health workers. Melissa Thomas is now an assistant professor at Heritage College of Osteopathic Medicine. Tell me, Melissa, about working with providers and healthcare systems that think they know what is best for the Amish community.
That's a great question. Can you all hear me okay? Good. Well, I often say that I don't believe that you have to belong to a community to help, but I do believe you have to know your place. And even after 25 years of working with Amish and Mennonite communities around the state of Ohio and surrounding states, I continue to be humbled by the experiences I've had as a community health worker who, again, is not a part of that community. One of the things we try to do is work with healthcare systems, health departments, other health agencies, and let them know the importance of having a trained local community health worker who represents that community. We've often found that some of the most prejudiced people surrounding Amish and Mennonite communities are those who live just right in the perimeter of those communities themselves, that think that they know what's best for communities without directly speaking with them. And we've learned through this program and through our training is that we make sure that all of our programs are completely community led. And we often say that I'm happy to talk about the work that I've done with the community, but I don't have a right to really tell you what they think or believe. And so we work very hard to encourage healthcare systems to hire community health workers who are literally from those communities. I continue to learn what I don't know about diverse cultures because I'm not a member of those communities. So we continue to encourage healthcare systems and agencies to hire community health workers who, again, have not only the training as a CHW, but have the cultural understanding of those communities.
So I understand the efforts at Project have led to further publications, especially deal with cultural sensitivity training, all the new docudramas that are on TV about the Amish.
Yes, Julie.
Yeah, I think she was saying about the Amish Mennonite docudramas, Melissa. Sorry to just jump in there.
That's all right, Susan. Thank you as well. Yes, in fact, I'll include a link here in the chat, but we did an exciting project as a result of all the new television shows that were coming out from reputable television stations that actually were perpetuating stereotypes about the community. And going back to the community members, we realized that there had never been a book written directly from community members. And so we did an amazing program, really a twist on a photo voice project, where we actually had community members allow a photographer to be invited into their home, and community members put together a photo book of photos of their daily lives with descriptions, and really provided a voice for community members to let them tell the world what they wanted them to know about themselves. And so the name of the book is called Life Through Their Lens, and it was completely community led. And I think what's exciting to see on a project like this is it really helps break down, I think, again, some of the stereotypes that we see in diverse population groups. And often in looking at those photos, we often see so much more in common that we have than we do differences. I think, again, it's another great example of where we can provide opportunities for communities to have a voice so that they can tell their story their way.
You know, Melissa, that's a perfect segue into our next guest, Teresa Campos Dominguez. And in your chat, you really talk about how health education and information lie in a top-down approaches to the ones that are based on lived experience. So Teresa, could you share with our viewers what is popular education?
Thank you, Julie. Yeah, definitely. Popular education is a philosophy and a methodology that we use to educate and organize community. It's also used around the world, but I am more familiar with the Latin American version. It is highly effective to support and empower community health workers so they can themselves support their own communities. It's also play a huge role. Popular education looks like similar like adult learning education. It's very interactive, but popular education is more collective, and the ultimate goal is the creation of more justice and equitable society.
I love that. So I'll incorporate popular education and with your experiences with the Latinx community.
In my own case study at the community level, I use popular education techniques like dynamicas to build trust. I use also techniques like social dramas and problem posing to help people identify the root causes of the problem and find solutions. I use also games to share information also as I reflect about how certain issues affect our community. I also use a lot of radio plays when we had to share a lot of information, and because it is important to keep us in mind that the way that we receive the education is the same way that we're going to practice in our community. Also, the writers in the other case studies, they use popular education for in the individual level. So Kelly and Liz Daly use popular education to increase understanding and gain input into the care plan for patients. And the other case study that we wrote at the systemic level, our college, Erica and Francis, use popular education to come to the mutual understanding of what it means to work in a decolonizing way in different racial ethnic communities. Using popular education to decolonization facilitate learning in support of the indigenous population should reclaim the value of traditional way of learning and the worldviews.
That's great. And it really seems like this is that people and the services and information that they received. And that brings us to the next role of care coordination, case management, system navigation. Kim Bush from Tyler, Texas. Can you share with us how community health workers have helped establish a navigation system there in your world? So Kim, I'm not hearing. Maybe speak up a little louder.
I was muted there. I apologize for that. But hello, everyone, and thank you, Julie, for the great question. This actually might take a little bit longer, but I'm going to trim it down and just give you the nuts and bolts of, during 2013, the University of Texas Health Science Center, also clinically known as UT Health East Texas, we established a navigation system utilizing certified community health workers in several of our primary care and specialty clinics. All of our CHWs were trained in an approved training curriculum from Department of State Health Services. And we also had given them some specialty training on obtaining and maintaining state, local, federal benefits and resources. So we developed a standard job description, a standard pay scale. We also incorporated a Department of Labor apprenticeship for CHWs. So that actually turned out to be very well received, because you have your someone learning to become a CHW from your journey worker CHW. So it's really kind of paying it forward type of thing. The process of navigation services usually begins with either an electronic referral through the EMR, or it could be a warm handoff, because a lot of times we would have physicians come out and say, okay, you need to talk to Tony over here, and he's going to help you in navigating that resource you need, or helping you find transportation for your next appointments, or help you in applying for Medicaid, or, you know, with that insurance question you have, whether it's Medicaid, Medicare, private insurance through the marketplace. So we've given all of our CHWs these training opportunities so that they could learn. Another route of referral communication is, you know, from any of our staff or anyone in the community. They just reach out to us for an email or a phone call. We also use now, recently, we set up a referral system through Aunt Bertha. So that's been a new thing that we started with. We also have an email system that is sent to a general email called Patient Services. And we do have CHWs checking that email daily and providing resources to them. So the goal is to remove barriers to appropriate care, such as reducing the utilization of emergency department visits, helping an individual find a medical home that's appropriate for them, and then just being there. Sometimes it's just providing that informal counseling or support, accountability, emotional support.
Hey,
That's really
great, because, you know, it's so hard when we hear about system navigation. Can you share with us really quick one of the hundreds of stories you know about how we can see this become a reality?
Yes, we do have a lot of stories. I think, you know, in the book we do have a few stories, but one of the things that our CHWs do say, one that's been progressing, Melinda, she talks about, you know, CHW work can be challenging, but it's also rewarding because it's meaningful. It's meaningful to the CHW, but it's also meaningful to the individual that you're working and helping with, you know, helping. So kind of a personal story that's also in our book, but I'll just trim it down a little bit. One of our former CHWs, Zola, she actually has been advancing her career as a CHW, so that's exciting. But she didn't start out as a CHW. She started out as a new single mom of 4. And she didn't really know how to, manage everything, paying the bills, going to work, getting groceries, transportation, who's going to do this, who's going to do that. And she just, began to be a little bit overwhelmed. And in all that, I met an individual and who was trusted by everyone in the community and, helped her and her family initiate goals and, supported her through those goals, which of course this lady was a CHW as well. And so, that intrigued Zola to start learning more about the CHW profession. And as she learned, she's like, this is me, this is what I want to do. And so, she became a certified CHW, and she has felt that she is blessed, but she is an asset and a blessing to our community, which she still serves. And she does mention in the book that she feels that God has given her a special talent to help others in her native language of Spanish and English.
Wow, healthcare is so hard to navigate today. I'm so glad we have CHWs here that help us get through these complicated mazes. And you know what? CHWs are providers of social support. Kim J from Chicago provides a beautiful story in the book about how gaining trust, getting to the root of an issue, and effectively coaching towards a solution makes a big impact to a person. Kim, can you share with us the story of Mrs. Jones?
Thank you, Susan. I absolutely can. What an awesome opportunity just to be in this moment right now, and even to share the experience about my time with Miss Jones and what the scenario was with her and her family. I was initially assigned to them as a community health worker to deal with asthma exacerbation and why this patient was still having continuous issues, and they had all the tools that they need to be okay. So one of my roles was to go into the home and do a home inspection and to just take a look around to see what was happening real time, boots on the ground. And when I got to the home, as a community health worker, your spidey senses are always tingling. So you're looking around the home, you're like, okay, this is could be a problem, this could be an issue, and this is the biggest concern. And I smelled a faint musty odor in the home, and I'm thinking this is a leak somewhere. And unbeknownst to me, the mom shared with me that under her rug was this entirely molded carpet that was really black mold that she had covered with another carpet because she didn't want people to know. There was fear about expressing to the management company about it because there was the thought that maybe they could possibly be evicted because it was something that they did on their part. But what I did was I partnered with her in support and advised her, you know what, I know we need to deal with asthma, but right now this is the top of the leaderboard. What can we do? And I collaborated with her. And we talked to the management company. They were shocked that they were living like that. And they came in and with my assistance with her and showing her what steps to take, we were able to get that mold mediated. And it was so bad, it was eating through the floorboards. But they came in within 2 weeks to do that whole floor over again and address that mold issue that was really making her family even more sick, and she didn't even know that was the issue. So when I spoke to her after we got the education part about asthma, what it is, how to take care of it, and we dealt with that mold, she said, Kim, really, I was depressed and I didn't know how bad that affected me. She said I did everything in my power to be outside of these 4 walls because I was so ashamed. She said, but when I saw them come into my house on that July morning and bring that new flooring in, she said a weight was lifted. And she felt like now I can have this cup of coffee and invite my family over to sit with me and enjoy and to be more social because that was something that was shrouding her that she didn't even know was really addressing some of her emotional issues. So as a result, she knew how to address situations within her home that affected their illness and talk to management without the fear of something negative happening for them. And as you can very well tell, the asthma exacerbations that her daughter was experiencing were now null and void. And so, with the refined education process and explanation as to how medicine should be taken and what things to look out for, they were empowered. But they needed somebody to be with them. They needed somebody there with them who understood, who wouldn't further shame them or make them feel any shame, and work with them to get that job done. And I was very proud to be the person to do that. And when I thought nothing of it because I'm like, this is just a day in the life, of community health worker. You do what you do. But she actually sent a letter to our hospital to tell them the whole story in her own words. And it has been a really a highlight of why I do what I do for the past 10 years. And I'm dedicated to the process.
Wow, Kim. I mean, that just so speaks to the heart, and it just really tells us, why you answer the why question right there. Kim, thank you so much for highlighting why it's so important to have community health workers involved, since it does. You just shared right there how it impacts those clinical outcomes. And we also know that community health workers also build individual and community capacity. Maria, you represent an organization in South Carolina called PASOS, which means steps in Spanish. And in the chapter focused on individual and community capacity, you talk specifically about finding the right people for community health worker positions. Can you tell us a little more about this?
Sure. We ground all of our work in the values that we collectively have come up, with together as community health workers. And those values are equity, trust, compromiso, which translates closely to commitment, family, education, and community integration. We're consistently doing like that self-reflection and communicating our values. We also ensure that these values are woven into all of our work and that it's reflected in the language that we use with our participants. And we also make sure that they're present in the activities that we will commit to. Because we see the traditional definition of empowerment limiting and potentially oppressive because of the whole dynamic between the holders and the givers of power. PASOS views empowerment as an unleashing of power from within the individual. And people are viewed with assets and as protagonists. Therefore, that's why we refer to the community members that we engage with as participants and not clients, or other words, reference words. And because we understand that leadership in a person is innate, we look for those qualities and the skills that community members hold. And they help us identify these natural born leaders. And then once they're recruited into the work, we begin the support of continuing to help them develop. And then PASOS partners with individuals to help them craft their own solutions, which then grows into this macro level solution, right, for communities. And CHWs are viewed as and promoted as experts and professionals with valuable contributions that are needed to be heard. Our training model, our trainings model the work that CHWs then turn around and do with community. Ongoing training is a time for learning, but it's also a time to build those trusting relationships. And our CHWs engage in peer-to-peer training, and lead CHWs provide continuous and regular coaching and mentorship to others within the communities. And that's how we build those capacities from within.
My co-host, we just can't hear you. You are somehow missing and we can't hear you. Will you try one more time?
Let's try this again. All right. So, Marie, can you tell us one of the stories that really highlights what you just talked about that demonstrates this building of capacity for our viewers today?
Yes, absolutely. So one of the stories that we shared in the book is the story of Anna, who immigrated from Cuba in 2004. And her story begins in Las Vegas, where she was working in maintenance departments at the big chain hotels that are in Las Vegas. And so she worked from sun up to sundown, trying to provide a living and create this dream of success for her family. She had a small child and she was married, but both her and her husband worked really hard. And you can imagine the type of supports that she could have used and needed at the time, especially having a small child and needing care for her son. And you know, things were really, really rough in that they didn't speak the language, and there was just a lot of need. So family from South Carolina reached out to them so that Anna and her family could explore what the opportunities were here in South Carolina, and also provided her with a way or means of supporting or helping sustain the family by caring for her aunt, who at the time, you know, was really at an older age and was suffering from Alzheimer's. Once her aunt passed away, she started to work in childcare. Anna, I failed to tell you that Anna's background in Cuba is that of an educator. So she is an educated woman who struggled a lot to, one, learn the language and navigate resources for herself. And with that, she knew that there was something bigger in doing for others. And so we met her through a grant opportunity we had with an organization called Hispanic Outreach, which offered an opportunity for Anna to engage her training, right, of an educator. And she had the opportunity to do prenatal education in Spanish, of all things, to Latina immigrants in rural counties in South Carolina. And so she continued to grow professionally through the supports that were provided, and her engagement with PASOS at the time, and so much so that she has grown and has been promoted to a statewide training manager for PASOS. And she has actually built and created the CHW certified manual that we utilize to train community health workers in how to better reach Latinx communities in South Carolina. She has earned her master's degree from the University of South Carolina. So we continue to see Anna grow, and it is just one of those stories of, you know, that really touches your core as to what is possible for community members. Thank you.
Yes, thank you, Maria. Now, one of the roles that community health workers provide is direct service. So here with us today, we have Mayfield Begay from Navajo Nation and Ramon Dillard from the Laguna Pueblos share information from 2 of over 500 tribal nation CHR programs from across the United States. I know direct service can mean a lot of things, especially to CHRs and CHWs. Mayfield, would you please share one out of the so many stories we have about how CHRs have used their skills to assess clients and then access critical care for their community members? Now, we were having some technical difficulties because Mayfield is on site in Navajo country right now, and so we're trying to make sure we can get her. Mayfield, are you here with us?
Can you hear me?
Yes, thank you.
Okay. Are we able to share the slides? I can't hear you now.
The slides are attached to the presentation for people to view those, but we don't have them up for them. But if you'll just tell us a quick story about what you know, how these CHRs have helped and used their skills, we would appreciate it.
Okay. What I want to do is I'm going to talk about the 3 slides that I have. In one of the slides, it has the standard of care, which is issued by Indian Health Services for tribal CHR program which includes health education, and that is to educate the public on chronic disease in our communities and monitor client. Many clients cannot readily access health facilities. Thus, it's the CHRs who are tasked with monitoring the health of the client, such as check-in appointments, medication compliance, etc. With case management, there are staff that work independently within the programs or with our health providers on a regular basis. With case management, CHRs assess their community for potential clients to be added high risk for close monitoring. In translation, many clients, especially elders, are monolingual, speaking only their native language, and CHRs usually translate for them. For transportation, it is usually done primarily on emergency basis or to bring clients to health facilities to receive health care. And I wanted to also talk about CHRs that are still able to provide services when we have inclement weather that poses impassable road throughout the reservation. So this is a story of a CHR. When the road to her client's home became impassable, she walked for about a mile to reach her client's home. And this client, or this CHR, went to check on her client to find out that she was without firewood, sitting in a cold home. And so she brought in some firewood, started the wood stove, heated the home. She also brought medication and food for the client and fed the dog, and then brought in more firewood for the client. The client was extremely grateful for the CHR coming to check on her and heating her home. And most of all, to be informed that the road grader was on its way to make the road accessible for her children to come visit her. Thank you.
Wow, that really saved that person's life. Thank you for providing that overview. Ramona, I know I remember reading a story in the chapter about Iris, who shared another life-saving story, but it was really related to medical bills and understanding that system. Will you share that story with our viewers today?
Yes, good afternoon, everyone. I'd be happy to do that. My name is Ramona Dillard, Director of Community Health on the Laguna Reservation, and Majeline, just her connection there is indicative of the situations and the circumstances that CHR programs work in tribal rural communities. The Wi-Fi and things are very unstable, and so a lot of times CHRs are having to go out to do the direct care and then try to work and link the people to communities or to clinics. And so Iris's story is very unique in the northern New Mexico area. She works for one of the tribes in northern New Mexico, CHR programs, and has been doing that for years. In terms of providing direct care, some of the care that Majeline mentioned, but most importantly, with the onset of Medicaid, which we know CHRs and CHWs have been the feet on the ground again and the interpreters of all of that mayhem that comes with understanding Medicaid, Medicare, QMB, all those terms. But Iris in particular, and I have to say that I've known Iris about 20 years now, and really her ability to learn, interpret, and understand, and then become a benefits coordinator, benefits services specialist in her community, along with the other things that she does, to be able to be that interpreter for that information. It is not easy to understand the ins and outs of Medicaid. It's really not easy to understand when you are a Native American person within this system, and Indian Health Service is supposed to provide all your medical care, and you get a bill. That's very scary, very daunting. And so Iris was very able to take those bills, interpret and explain, what really was going on with those bills and really to ease that individual's fears. A lot of times individuals are referred to other systems outside of Indian Health Service, and with that, they then are having to figure out then how those bills get paid, which really shouldn't be. So I have to applaud Iris and not only her doing that, but also in training and teaching her staff how to be those benefits interpreters. I know in a lot of hospital settings, those persons are there, but it's very unique when we have CHRs in those roles in the homes and in the community to be able to do that. So that's just one of the stories, but again, CHRs are unique. They're just like CHWs, and I'm so glad that we've made that connection. So we really consider ourselves sisters. Thank you.
That is amazing. Thank you both so much to Mayfield and Ramona. What an amazing group of community health workers and CHRs and all those terms that fall under the umbrella here with us today. Can we get a round of applause? Let's give a round of applause. You guys, fabulous, fabulous. So we really want to thank our viewers too for being here and supporting the work that they do. So we will discuss two more roles. So we've really covered a lot of groundwork today. Before we go to our viewers for questions, so viewers get ready. You have a chance for your questions for our panelists in just a moment. Outreach is a key activity for community health workers, and let's start with our outreach role with a case study about a three-arm intervention with how the use of handheld technology and access to education and community health workers can improve type 2 diabetes disease management in rural Georgia with Gabriella or Gabby Boskin. You work with the National Rural Health Association as the Senior Director of Program Services and Development. Tell us a little bit about this study and how community health workers impacted your outreach efforts.
Thanks, Julie. I'm excited to join you all. So at the NRHA a couple of years ago, we had the chance to partner with the Verizon Foundation, the Northwest Georgia Partnership, to do a one-year-long project to track type 2 diabetes and community health worker intervention. So we were able to recruit 300 patients in the Northwest Georgia area and had 100 patients in 3 groups. So first group, control group, no intervention. We just tracked their A1C in year 1, in month 1, month 6, and month 12. And with the only exception of a few patients that were really, really sick, so we actually pulled them out. We wanted to make sure they did get some help as their A1Cs were very, very high. And then we had group 2 that received community health worker intervention. So this group of patients had monthly interaction at minimum with their patients and their community health workers. They received whatever help they needed, if it was transportation, if it was educational, or just help connecting to services that they may be eligible for. And then group 3 received intervention with community health workers and technology. So Verizon provided handheld technology, so tablets, Fitbits, and a glucometer that we were able to donate to the patients, and they were able to download a bunch of health tracking apps. So the apps that you can use to track your calories, to track your glucose levels, and they also had the ability to have video conferences with the community health workers. So that gave them an extra layer of communication, especially in rural areas where transportation and distance is such an issue. So this really provided an extra layer of access. We tracked the 3 groups for the year, and the results showed that group 2 and 3, having that community health worker intervention, they did have lower A1Cs at the end of the project. There wasn't that much difference between group 2 and 3, so the technology itself didn't necessarily make a difference, but we were able to show that community health worker intervention does affect chronic disease outcomes in a positive way and possible some cost savings in terms of healthcare costs. And so a couple of things we learned from this, obviously working in a rural community, in a small community, there was some cross-contamination of the groups in terms of research. So some of them, we even have family members that were in different groups. So obviously if you were in group 1, but you saw somebody with a tablet, they would use it, or they went and got a Fitbit on their own, even if they weren't in the Fitbit group. But all good things that helped. So one thing we would have done differently is maybe have different communities so there wasn't as much communication between the different groups. We were also able to do a a sustainable aspect to this research and just show people how they can use the technology they already own to try and help their health outcomes. So overall, we had focus groups that really thanked us for bringing in community health workers, and that they finally felt that they were heard and that somebody cared for them and their chronic disease and their health outcomes. So it was a really valuable experience and a great project that showed the value of community health workers and how we can help patients.
Thank you, Gabby, for sharing how research and health interventions impact outreach. Now, Ms. Catherine Gray Haywood, who is the Executive Director for the Louisiana Community Outreach Network, gives us a little bit more of an intimate look at outreach. Now, Ms. Catherine, in your chapter, you say you have to build a relationship. Tell me what you mean by that.
Okay, so let's go way back, whatever year we want to go to. But when I first started doing this and I was working around HIV and AIDS, the thing was you just couldn't go in a community and say, hey, I'm here. I want to talk to you. You need to learn how to do this. You need to have more information. That's not how that works. People had to get to know you and you needed to get to know them, but you needed to be able to build trust and a relationship with people in the communities that I work with. Even today, you still have to do that. You know, you just can't go in and say, I'm here to tell you what to do. Not gonna work. It's not gonna work at all, right? So that was the beginning of how you started working with community and building trust. And then moving forward, even in some of my other jobs, you use the same, you do the same thing. You just can't go in a community saying, I know what I'm talking about, and you need, because, hey, they may not feel they need anything, or they may not trust you. So that means they're not going to get the information that's needed. All right, Susan, you have more questions?
Yes, absolutely. And I hear you don't say no to Miss Catherine. So thank you for sharing that perspective. Finally, community health workers are increasingly participating in evaluation and research, reflecting community-based participatory research and citizen science. Brindali Rodriguez, who is currently director of the Chula Vista Community Cooperative, share with us a story about how community health workers as stakeholders have impacted research intervention and clinical trials.
Okay.
Yes, certainly.
I'm sorry, I haven't gotten back with you, and I was looking at my calendar, and I think most likely I'm on that.
Hi, so for my presentation, I would like to share a little bit more on these cases. We have done a lot of interventions with CHWs as contrast with standards of care, and that involves like having CHWs actually having like a toolkit with several at-home screening, like for hepatitis, for colorectal cancer, for cervical cancer, HIV, and others. And the CHWs and promoters within our research teams have gone beyond the simply educating, which is important, education and outreach and study recruitment, but then have been able to bring back their input in several ways. Through their cultural and linguistic competence, they have made and convinced the teams to create a welcome video for the principal investigator to greet the participants, making that personal feel into the study in both English and Spanish in this case. Also, they have provided cultural competence by making adjustments with the plastic bags of the human tissue, and there's more detail of that in the book. Also, they have incorporated for the health screening tests added checkboxes in the system for a consistent way to track and be standard in the follow-ups that the research team had to do. And also they added and expanded much more rich detail in their progress notes on each of the cases, because then that information was created more of a contact log that gave us the rich detail of the follow-up activities they did addressing social determinants of health, like how many referrals and linkages with the food safety and food boxes distribution, with vaccines for children, and that added a layer not only on the data collection for the intervention itself, whether it was cancer, diabetes, colorectal cancer, but also on that social determinant of health assistance that CHWs and promotoras provide. And all that within that structured research training for CHWs. We don't have time to talk to more today. It's available in English and in Spanish, and it was validated across 4 states. So we're happy to share it in the chat.
Well, thank you so much for that thoughtful answer. And while we don't have ample time today to discuss the PCORI project on engagement and mobilization for the PCOR curriculum development, I really want people to know about it. So please go and check this out in Chapter 14 of the textbook.
And we did provide a link in the chat too, so make sure you check it out. And we want to thank all of our celebrity authors for their time today. We just have a few more minutes for some questions. And so we're going to check the chat for the questions because we had asked you to put them in. But, you know, if anybody has a question or anybody wants to respond on our panelists, because they are all subject matter experts on this, we will go ahead. So I'm going to ask our moderator, our technician, if she'll ask us the first question.
Thank you to Joshua Collier for this excellent question. Would any of the participants please speak to how they've used these wonderful stories about CHW impact in efforts to help support the work of their respective organizations, such as seeking additional funding, growing their organizations, or integrating their story with data demonstrating CHW impact?
From our panelists, anybody want to respond?
Well, let me jump on that one because I have to tap out momentarily. Yes, these stories have been used effectively in bringing that qualitative piece to research and to implementations of programs, because it's one thing to see the numbers, but it's another thing to hear the stories behind those numbers. And as a result, new programs have been implemented and fashioned around what community health workers do to connect community members to better health care, bringing that level of understanding, bringing that level of health literacy to a place where patients, clients understand, and they can actually take advantage of the services that are available to them they would otherwise not know. So sharing the stories is the most powerful piece of a community health worker's role because it changes, morphs daily. It's never the same day twice. But one thing you can be sure of is that the interaction will be a complex connection when you meet the person because they're multifaceted. It's not just one area that you see. You may come there to address one issue, but when you get there, more things come out because of those social determinants are there and they layer on to the complexity of the clients that are before them. So when you talk about the stories, they are invaluable. And I encourage all CHWs who are in programs to even category your stories and write those down because they are the most telling piece of the work that we do because nobody does it better.
I can respond to that as well. For us at the local community health center, we did not specifically use the story that I told or the video I did, but in the team video with the Boston Medical Center and other health center, we actually share someone who put it in a a proposal for a grant for the community health worker up in Boston, and they use our video and our story, and they actually, somebody from the HHS actually saw it, and then they asked, to use that video to share with their staff, in terms of what all their, impact of the community health worker have in terms of the work and the things that was happening in the pandemic. So I think that was impactful, and looking at a labor force is a community health worker.
I just want to say real quick that, this is one thing that I'm learning to do and practicing to do as well, but we should all really learn the art of telling the story in a way that really makes a good visual for funders and potential partners and just amongst our peers, because the magic happens when people start connecting what my life looks like compared to someone else's life, and that is where the power is held. So I encourage everyone, that's something that I myself still learning to do better every day. Just want to make that point. Thank you.
Thank you so much, Maria, because I do know, especially when you're talking about legislators, you need that story to connect them to their constituents to see how it impacts, who they are representing. So yes, these stories really do have such an impact. I just wanted to make sure none of our other panelists wanted to share anything else on that particular question before I move to the second one.
Just real quick, in terms of stories, stories are cultural. That's part of tribal communities, storytelling. We call them testimonials sometime on the other side, but I think the beauty in that is that puts a face on the issue. Sometimes we get a little concerned in tribal communities that data disconnects people's faces from the real story. So for us, going before DHHS and then giving these stories to tribal leadership who gets to go before Congress all the time, this makes it real for them. And we want to make sure that we tell the story that behind that story are real people, and data can sometimes be a disservice because it looks just like a number. But when you get that skill down to connect it, it makes that data real for people. So just wanted to share that. And our CHRs do that really well with their tribal leadership. Thank you.
Thank you, Ramona, so much for that. I know we're dwindling down. We had one more question, Sunny. Would you go ahead and ask that question for us?
I'm actually going to bump that last question to a question that 7 people have asked. Could you please share where the book can be purchased?
Oh, okay. The book is published by Springer, and you can go to the Springer website, and I am doing a disservice because I sure am not doing that, but it's a Springer publication. If you just do a Google search for promoting the health of the community, it'll come up. They have both an e-version and a hard copy version, and they're coming out with a paper version soon. Well, everyone, we're almost at the end of our session for our today's episode of our Community Health Worker Review, and I really hope that you'll join us the next time we have another session with another great celebrity panelist group of community health workers who go out and make a difference every day in the community. Thank you all so much. Any other comments from our panelists before we go? Oh, you want to say something. Come on. All right.
Thank you for all the participants for joining us and hanging out, stick it there with us until the end. Thank you. Thank you.
Right. We had some participants with us today. Thank y'all so much. Y'all have a great rest of the Unity Conference.
Thank you. Bye.